no introduction. Dr. Yogesh Shastri, who is organizing this event. He is the HOD and Specialist Gastroenterology at NMC Specialty Hospital. I have known Yogesh for many years. He studied in Central India and has over 22 years of experience in gastroenterology, therapeutic endoscopy and hepatology. He did advanced training in his GI in Germany and France. He is here in NMC for over a decade now, and he started the endoscopic ultrasound program in UAE, and he chairs the EUS program at NMC Specialty. Yogesh?
Thank you, sir. Thank you for being here. So I will take you through my journey of 1000 EUS in UAE. So first I would like to introduce to everybody what is endoscopic ultrasound. So it's basically a fusion of endoscopy and radiology. So it's a fusion of endoscopy and ultrasound. So normally as endoscopists we are tuned to seeing colors. We are always trained that we see within the lumen, so we have a tunnel vision and we see colors. But when you combine it with a radiology, it becomes EUS, which is endoscopic ultrasound. So it's a marriage of two technologies or two branches of medicine. That's why it has a little longer learning curve for any endoscopist, because normally you're training in endoscopy. So there are basically two types of endoscopies in EUS, which is radial echoendoscopy and linear echoendoscopy. So in radial, the beam or the ultrasound beam is at the 90-degree as compared to that of the endoscopy axis. So it gives us an overall picture, it gives us an overall image of like a CT scan. But the downside of it is that you cannot do therapy with it. Next is linear echoendoscopy, where it is parallel to the axis of the endoscope, but the advantage is you can do all the therapies with this using a needle or any instrument which is coming out from there. So this is the processor for EUS scope. So this is a small video. Can you play the video? So this is a cartoon animation for us to understand what is echoendoscope or endoscopic ultrasound. So this is the linear echoendoscope, and it has an accessory channel through which this needle comes out, with which we can go outside the lumen of the GI tract and we can take biopsy. As an endoscopist, we traditionally take samples from within the walls of the intestine, but with this you can go out of the wall of the intestine and can take samples. So that's why it is a different modality as compared to that of normal endoscopy. And the most important organ which you can see with it is the pancreas, which is lying behind the intestine. It is lying between the spine and the abdomen, so it's not very easy area to take a sample or biopsy from, but as you can see, you can put in a needle through this and you can take a sample from there. So what indications we use EUS for? EUS basically allows us to see any organ which is lying outside the lumen of the intestine. So it depends on where you are located. So if it is in the esophagus, it allows us to see the mediastinum, the lymph nodes, you can see heart, you can see azygous veins. In the stomach, it will allow you to see not only the stomach wall, you can see pancreas, liver, gallbladder. From the duodenum, you can see ampulla and gallbladder, CBD. And from rectum, you can see around the rectum. So you can put the scope not only from the mouth, you can put it from the anus, and you can see the areas around the rectum. So these are the indications where we use EUS for. So we basically, the most important organ which we see with the EUS is pancreas. As I told you, it is a difficult area to visualize. CT scan is one of the best non-invasive modality for examining the pancreas, but EUS has the advantage that it can pick up even a small lesions which might be missed out by any cross-sectional imaging, and you can take a sample from it, which we cannot do with other modalities. CT scan, CT guided biopsies you can do, but many a times it is risky and you cannot reach to certain areas of the pancreas. You can see biliary stones For diagnosing bile duct stone, EUS is the best modality because it can pick up even a small stones which can be missed by MRCP. It can also be used to stage the various cancers in the GI tract, esophagus, stomach, pancreas. You can use it to examine various lumps and bumps in the GI tracts, any submucosal swelling, any swelling in the intestine. You can put a scope and you can see what lies behind, because endoscopes tells us about the skin, the covering of the mucosa, but EUS tells us what is beyond it. So that's the advantage you have with this technique. You can see the mediastinum, you can see the various biliary organs. Then the therapeutic indications of EUS, which is coming in a big way since last 1 decade, and they are basically, you can use it to give special medicines in the celiac plexus to give pain relief for patients with intra-abdominal malignancies. You can use it for draining biliary and pancreatic system where you cannot drain with endoscopy. You can put some markers for providing radiotherapy. You can do gallbladder drainage in very sick patients where surgery is not possible. And nowadays you can join like a surgeon between the stomach and intestine in patients who are sick, who are not fit for surgery, and it can be used as a palliative in the palliative setting in patients with advanced malignancy. So my journey, I started from Tata Memorial Hospital. This was way back in 1999, and as a resident, GI resident, when I joined there, EUS was a little bit uninteresting for me because it was black and white. EUS doesn't have colors. The endoscopy always is very colorful, but EUS is only shades of black and white. So as a resident, it was a respite when a EUS case is going on, because that was a time when you can take a bit of break. And Professor Dheer was my mentor and teacher there. So he was one of the first to start EUS in India. So I was fortunate that I was there, but then I started getting interest on it. I became passionate about this technique. Then I went to Germany to get trained in ERCP and EUS. Followed by that, I was in Marseille with Marc Giovannini, who is a world leader in endoscopic ultrasound. I established EUS setup in one of the private corporate setup. Came to NMC 2012. I wanted to start this program when I joined there, but there were challenges to establish EUS program. It took me almost 3 years to start this program. There were various hurdles which I had to face to start this program. So most important is it's very expensive equipment. It's like a white elephant, EUS. And the time required to perform this technique or a procedure is almost 3 to 5 times that of a routine endoscopy. So the reimbursements are low. It is time consuming. The insurance approval was an issue because it was a new technique, so insurance were not very well aware of it. Then you need a expensive consumable for this, because when we put a needle into a tumor and we use it as per the international safety standard, you cannot reuse them. So these were the hurdles to set up this thing. Then you need it like a GA setup. You need a OT kind of setup for this, because this procedure takes much longer time. It can take up to half an hour, 1 hour, so patient has to be sedated. Then there is need for more planning to do a procedure. There was lack of awareness about this technique. So to start the program, you have to make people aware of it. So we had to have a lot of sessions with the insurance companies to convince them that this is a new technology and it will help us diagnose and treat our patient better. There was need to educate colleagues. There was need for retraining, regular participation in various meetings and workshops. So we are first to start EUS program in private sector in 2015. We reached our first milestone in 2016 December. Now I'll take you to my audit, which is a partly retrospective and partly prospective. So we did 1,004 procedures till last week. There is a skew in the numbers in the gender between male and female. As you see, the number of males are more. That is because of the population here, because there are mostly male expats here. That's why. It doesn't mean that the diseases are more common in male, nothing like that. The number of linear EUS was 50-50%, almost 50% radial, 50% linear. we did FNAC in 350 patients, and the age range of the patients were from 14 to 89 years. That is another beauty of UAE, because it's a melting pot of civilizations and various nationalities. So I had the privilege of doing EUS procedures in patients from 53 countries, and this is the breakup of patients from various parts. And this is a minor representations of patients from various parts of the world. We used FNA in 350 patients, and FNA needles are of two types, which are basically fine needle aspiration needles, which were used earlier. They are still used for cystic lesions in the body, but nowadays we have moved to FNB needle or core biopsy needles. So we used almost 50% of the patients. We use the core biopsy needle. They give more yield. They give better diagnosis for patients. So they are the new needles which were used in 50% of the patients. Also, we used a new type of needle which is not very common in the world, which is called as puncture biopsy needle. I'll discuss a case of this later on about it. So therapeutic procedures constitute a small percentage of EUS which we perform, and the main procedures which we did was pseudocyst drainage. We did liver abscess, pelvic abscess drainage, pancreatic cyst biopsy, and pancreatic cyst aspiration in our patients. We diagnosed 104 malignancies amongst patients, and the lion's share of these malignancies were pancreatic tumors, which constitute about 1/3 of these patients. The pancreatic neuroendocrine tumors were seen in 16% of the patients, so almost 50% of patients had pancreatic malignancies, and rest of the patients were as shown in this chart. It's very important for us to do any procedure safely. EUS is quite safe procedure, and we had our share of complications. We had pancreatitis in 2 patients. One patient had very severe pancreatitis who had to be admitted in ICU, and he was hospitalized for a couple of weeks because of this. And we had bleeding in 4 patients. 2 had to be admitted. 1 required blood transfusion, and infection was seen in 2 patients. And it goes with the world literature of safety and procedural risk of EUS. And as you can see, pancreatitis is seen in roughly 1% of these patients. Another important concept which is there in the world about endoscopy is EUS ERCP hybrid suite. So we started this EUS ERCP hybrid suite. And what happens here, that in the same suite we have endoscopic ultrasound facility, we have ERCP facility, we have fluoroscopy which is required for ERCPs and some of the EUS cases, and we have possibility to give them anesthesia, that is a general anesthesia setup. So this has the advantage that you don't have to give patient again sedation, you have to bring them for another procedure. In one setting you can finish the entire procedure. So this is of prime importance in patient with CBD stones, because what happens, any patient with CBD stone, you do them the endoscopic ultrasound, you find a stone, then you do ERCP on another sitting, but here you can use it as a diagnostic cholangiogram like a MRCP. You do a EUS, you find a CBD stone, you do the ERCP for that patient. If you don't find a stone, you can spare the patient from ERCP, because ERCP is one of the endoscopic procedure which has one of the highest risk and complications. So by this you can triage the patient and avoid risky procedure. And same way it can be used in patient with malignant obstruction. If you find a patient with malignant obstruction during EUS, you can take the FNA. If you have a ROS possibility, you can diagnose it at the same time. You can assess whether the patient will be a candidate for surgery. You can put up a stent depending on the decision what you have taken. If it is resectable, you can put a plastic stent. If it is unresectable, you can put a metal stent, and you can treat them better in a shorter time. So I'll discuss few of the cases, what we did, just to highlight what we have done. So this was a young lady who came with severe epigastric pain, vomiting, deranged liver functions. She had history of lap cholecystectomy done 10 years back, and ultrasound showed dilated CBD. So this was the MRCP. Can you dim the lights? This one. So we did the MRCP for this patient, and you can see that the CBD is mildly dilated, but there is no stone seen in this patient. Patient had a CT scan also, which also did not reveal any stone. But patient continued to have pain. She came to the ER, and we did a EUS for this patient, and as you can see, there's a small stone in the lower part of the CBD, which is casting a shadow. Can I have another pointer? It's not showing there. So this patient was taken up for ERCP in the same sitting, and so this is the cannulation. This is the papilla. You are cannulating. You pass a small plastic catheter into the bile duct. Then you take a wire which goes across this, and you have fluoroscopy X-ray which tells us in which direction you are. Are you in the right duct? Then you have electric cautery. Like a surgeon, we take a small cut in the ampulla, which has to be really, really very calculated. Then we use like a balloon to sweep across the bile duct, and we can remove the stone. And as you can see that there was a very tiny stone which was there, which was the cause of this obstruction, and patient got relieved from these symptoms. This was another patient, 66-year-old young lady, 66-year-old female, I would say young, 66 years, with history of weight loss, anorexia, severe backache. She had a pancreatic mass lesion in the head and uncinate process with very high tumor marker for cancer of the pancreas. She undergone the EUS-guided FNAC from another facility, and it showed adenocarcinoma or neuroendocrine tumor. The point is that the treatment of both the diseases are entirely divergent, opposite. They are different. So we needed a definitive diagnosis. The other option was for this patient to go for a surgery, which was too much to do. There was the option of CT-guided biopsy or a repeat EUS FNAC. For this patient, we used a special biopsy technique which is called as puncture biopsy. It has been used in very few patients in the world. It is like a crocodile mouth. This is like how we take endoscopy biopsy. So you pass the needle, you take a biopsy from the pancreatic tissue, and you remove it. So this is the biopsy which we used. This is a video which is showing this technique. So this is the tumor. As you can see, the black thing, it's a tumor. And we can see whether there are any blood vessels. This is the needle which is coming in, and you open the jaw and then you close it. You take the sample and you remove this needle. The point is this needle is 1.5 to 2 times of the diameter of the normal needle which you use. And here we are going across the duodenum. So you are piercing the wall of the intestine, and then you are going into the pancreas, you are taking the tissue. So it carries high risk. There is a risk of injury to the intestine, there is a risk of bleeding. But the advantage is that we can take something like a solid piece, like how you take, and it gave us the diagnosis for this patient. So we presented our data in an international conference of 10 cases, and it was later published, in which the number of cases which we contributed was highest in this paper. So this was another case, which was 39-year-old patient, which was referred to us for abdominal pain. The patient had chronic pancreatitis and large pseudocyst. As you can see, this is collection of fluid in the backside of the stomach, which is seen in MRCP also. This patient underwent endoscopic ultrasound, and in this you can see a large collection of fluid, and there are various ways to drain this fluid. This is a large cyst. You can drain it by surgery, you can drain it by endoscopy blindly, you can drain it by radiological method. But nowadays, EUS-guided pseudocyst drainage is standard of care. So you have to check that the thickness of the stomach wall through which you are going is small enough. Then you put a Doppler to see there are no blood vessels intervening. Then you put a special catheter across it, which can burn through the wall of the stomach. You can use fluoroscopy, the X-ray, to confirm the position. Then this is a one-stage procedure in which you can open like a umbrella inside the cyst. You pull it across, and then you can release the other side of the flange into the scope, which will lead to drainage of this pus into the stomach, and it can relieve the symptom which patient is suffering from. As you can see, the pus is flowing into the intestine to relieve this patient from the symptoms. And then you'll repeat imaging, and then you'll remove this stent in the next sitting. This was another 42-year-old male who came with high-grade fever, sepsis. The inflammatory markers were very high. And when we did imaging for the patient, we found there is a infection or abscess in the caudate lobe of the liver. So this caudate lobe of the liver lies behind, so it's very difficult to access it by any radiology techniques. Normally for liver abscess you can just put a needle from the stomach or from the abdomen and you can drain it. But since this area is lying behind, it's difficult to access, so a surgeon requested that if you can go and drain it. So we put in a needle into this abscess from the stomach. We could aspirate this pus from the patient, and it was sent for examination. Patient was given antibiotic as per the culture results of this pus, and patient got relieved. He avoided interventional procedure, he avoided surgery. So this is the advantage of minimally invasive technique to treat these patients. This was follow-up after 8 weeks. There was entire resolution in symptoms. This was another 46-year-old lady from Philippines who presented with lower abdominal pain, shortness of breath, fever. She had high inflammatory markers, and CT scan showed a large collection in the pelvis, around the rectum. So we had the question whether the patient should go for surgery or any minimally invasive technique. So we subjected this patient to the EUS guided drainage. So this was done from the rectum, from the anus, and as you can see, this is the large fluid collection into the pelvis. And it was punctured with a needle, and we put a different type of a stent. It's again a metal stent, and it could drain the pus from this pelvic abscess. So we were the first to do this in our group. These are some of the images of the same procedure. Repeat CT scan showed resolution of the lesion. Patient was discharged after a couple of days, and she recovered completely. So this was another 36-year-old lady with low back pain, fever, weight loss, and there was high suspicion of tuberculosis in her, and MRI was showing there's a collection in the pelvis with suspected TB, but we need a tissue diagnosis for this patient, and this was the MRI which was showing the collection. And we could take the specimen from this collection, and so we used the EUS to drain this abscess, and this was the pus which came out, which was sent for analysis. It came out to be tuberculosis, and patient was treated with anti-tubercular therapy. She gained 10 kilograms of weight over a period of time, and she recovered completely. So to summarize, EUS has an established role in evaluation of GI tract cancers, some mucosal lesions, various pancreatobiliary diseases. The advances in EUS technology is helping clinicians, endoscopists, surgeons to treat the patients better. EUS is here to stay. It is a well-established modality. It can be used in various indications. Newer indications and procedures are evolving, and therapeutic EUS is very fast, rapidly growing field. Sky's the limit, and I thank my team to help me all the time. Thank you.
Thank you, Dr. Yogesh, for that wonderful lecture. It's really wonderful to see the progress that EUS is doing in Abu Dhabi and in this part of UAE under your constant guidance and supervision. 1,000 cases is a milestone, and I'm sure you will reach 10,000 very, very soon. Any one or two questions? Somebody wants to ask anything?
Can I ask a question?
Yes, please.
Thank you, Dr. Yogesh, so much, and congratulations for 1,000 cases.
Questions which always our patient ask. What do you think about this idea about the tract metastasis? If we take a biopsy from the pancreas or the liver, turn out to be a malignancy, patients are very worried about these tract malignancies. What do you think? What do you tell them?
Sorry, Zahir, I didn't get the question.
We're talking about the tract malignancy. If you take a biopsy from the pancreas or the liver and turn out to be a malignant lesion, patients are worried about the tract malignancy. What do you tell these patients?
Okay. So the tract seeding is one of the rare complications of US FNAC. The advantage in the pancreas is that usually you take a biopsy from the duodenum, the second part of duodenum, and when you take the biopsy, usually if it is a curative resection, then they will do a Whipple's procedure. So they will be resecting that part which will be where the tracking could have happened. So that is the advantage of it. If you do a CT guided biopsy, there will be a tracking from outside. So it will be impossible to remove that. But if you are doing EUS guided biopsy, you can remove the entire as a part of specimen in Whipple's procedure. And in liver, we don't usually perform EUS in the sense you do it for EUS, the lesions in the liver which are supposed to be metastatic, then the disease is already spread. So even if there is a tracking, it is the patient already had a metastatic disease, but it will change the management for that patient, because if you are planning for a curative resection and you prove that there is a liver metastasis or a spread anywhere else, then the entire spectrum changes from curative to palliative settings. Another thing, this risk of tract seeding or needle tract seeding is extremely uncommon. There are few case reports of it, because the thin needle which you use, the chances of tracking is very less, because there is a sheath which covers the needle. So the needle is covered by a sheath, and that sheath is coming out of the scope when you are doing FNA. And only the needle comes out of that sheath, it goes and punctures the tumor, and then that needle goes into the sheath and you remove entire sheath. Of course, there are certain case reports there, but it is extremely uncommon to have tumor seeding during the procedure.
Thank you very much, Dr. Yogesh.